All right. Hello, everyone. Thanks for joining. Tonight's seminar is regarding prostate cancer. We're going to be reviewing some things that are important in helping to diagnose prostate cancer, what the incidence of prostate cancer is, and what we can do to help men that are diagnosed with prostate cancer. So just a little bit about me. I am a practicing urologist here in the Hudson Valley. I have been here in the Mid-Hudson Valley for the past 8 years or so. I grew up in Rockland County, and something that attracted me back to the area primarily is just the opportunity to treat the community I grew up in. I find that valuable, part of my, personal satisfaction when I can help a fellow neighbor out and enjoy still bumping into my patients in the area. So my main office is in New Windsor, and I have a website. If anybody's looking for further information, can easily navigate. It's www.singhurology.com, SINGH urology.com, and our office number is 845-437-5000. As I mentioned, I am from the area. I went to undergrad in SUNY New Paltz and pursued my medical education down in Long Island at the New York College of Osteopathic Medicine. And then moved to Philly for about 8 years, where I pursued a residency in urology and then a fellowship in urologic oncology, which allowed me to spend an extra time to really fine-tune my ability to treat cancers that affect the urinary tract. And so my personal interests are not only addressing cancers, including prostate, bladder, kidney cancers, but also helping some of the side effects that these cancers can result in, such as erectile dysfunction and urinary incontinence. Firstly, most patients are kind of curious to understand what even a urologist is. It's not until you need a urologist or you go to your medical doctor who says, hey, I think you ought to see a urologist, and you wonder what truly a urologist is. So that you understand, a urologist is a surgeon who's trained in not only the surgical management, but also the medical diseases that affect the male and female urinary tract. That is often a surprise to many because we do see women. And in fact, probably about 30 to 40% of my practice includes seeing women. And that primarily includes the management of urinary issues, urinary incontinence, as well as kidney stones. And also helping men in their reproductive organs. That includes the prostate, the testicles, and the urinary channel in between. So what would be the most, or the top 3 reasons a patient will come see me in the office? And that top 3 includes the management of prostate cancer, benign prostate growth, or urinary symptoms that are associated with prostate enlargement, and also erectile dysfunction. So these are probably the 3 main reasons diseases that I take care of on a daily basis. And so since we're going to be talking about prostate cancer, I figured it's important to kind of establish what the prostate is, or what is a prostate. And so the prostate is a gland that sits right underneath the bladder and in front of or anterior to the rectum. So this diagram illustrates the urinary channel that runs from the bladder actually goes through the prostate. And where the prostate sits is in a delicate spot. We do recognize that the nerves and blood flow that carry stimulation to the penis during an arousal or to achieve an erection run within millimeters of the prostate, and it sits in front of the rectum, so that's why your doctor will often ask to do a prostate exam by inserting a finger, or what we call a digital rectal exam, so they can get a rough idea what the prostate feels like. The normal size of a prostate is that of just roughly a size of a walnut or a golf ball, and that's somewhere around 20 to 25 grams. And so the other question most guys ask me is, well, what the heck the prostate is for? And, why is it important to men? Well, it is part of the reproductive system. It is important because the channels that help with excretion of the seminal fluid or the semen hook up to the prostate. So it's a very important part of the reproductive system. Without the prostate, you can't ejaculate. And so some of the patients that will help with prostate cancer management, that will pursue prostate removal, that's one of the side effects we'll get into, is the inability to ejaculate. And so when we look at what the incidence of prostate cancer is, I wanted to share some data regarding the incidence. In the United States, and the last time the count was put together or the database put together is from 2017. So that's the most recent numbers. Anything more recent are just estimates based on these numbers. So the number of new diagnoses of prostate cancer in the United States were somewhere around 207,000, and roughly 30,000 men die from prostate cancer every year. And so when we rank the incidence of prostate cancer as what are the cancers that are most prevalent in the United States, skin cancer is number one, but excluding skin cancer, the number one diagnosis, the most common cancer that's diagnosed in men in the United States is prostate cancer. Now, fortunately, for most prostate cancer are a slow growth, and so the one thing that I want to kind of dispel is that we often hear as urologists that men will come in and say, "Well, doc, I heard that I will probably die from or die with prostate cancer rather than from prostate cancer." And the difficulty in just making that generalized broad statement is that there's still about 31,000 men that die from prostate cancer every year. And because it's slow growing and it affects men as they get older, I think that probably is an undercount or a less than accurate number, because most of the time as men get older, oftentimes what's recorded on the death certificate may be a heart attack, where it doesn't really capture the morbidity that a man is experiencing from prostate cancer that has spread. And so that often doesn't get captured because, again, it's slow growing. Many men in their late stages will often face side effects of cancer that spread outside into the bones, or obstructing the urinary channel, or having inability to urinate. So that often doesn't get recognized when we talk about the number of men that die from prostate cancer. In New York State itself, there's about 15,000 men that get diagnosed every year, and roughly 2,000 men that will die in New York State from prostate cancer. And just putting into perspective where prostate cancer ranks, these numbers are from New York State. The second most common falls, and this is in men, the second most common diagnosis in men includes lung, followed by colon. And as a urologist, just to kind of put into perspective what else I'm treating, urinary bladder cancer falls under number 4, and that's something as urologists treat. And then kidney tumors falls in as the top 10 as well. And so as a urologist, I'm often taking care of 3 of the top 10 cancers that men, and again, women will experience, because it does affect the urinary bladder and kidney, both men and women. Again, putting into perspective the mortality, prostate cancer falls as the second deadly cancer, and it's followed by distant lung cancer. So we do recognize lung cancer tends to be more aggressive than prostate cancer. What are the risk factors when we talk about pertaining to prostate cancer? Well, clearly age is the strongest risk factor. This is a disease that affects that of the elderly. The older you get, the higher the incidence of prostate cancer. And in fact, most men that are diagnosed with prostate cancer are above the age of 65. I do see men, I've seen and diagnosed and treated men in their mid to late 40s as well. They tend to be correlated with some sort of genetic predisposition. And so I can't safely say that if you're less than 60, you're not going to get this cancer. So that we often recognize that prostate cancer screening should begin in the early 50s. We do also recognize that African American, or I should say Black men, tend to have a higher incidence or risk of developing prostate cancer. The exact reason we don't quite know. Many argue it may be socioeconomic, that the ability to pursue health care and routine healthcare may be impacted and may be related to socioeconomic reasons. This is a chart graph that goes over, again, the incidence of prostate cancer as you get older, and that's what this curve is showing, that the older you are, the higher the incidence of prostate cancer. This is both seen in both men who are white and black. The discrepancy that we see on this graph is that our black men in the United States tend to have a higher incidence, and that's what this graph is showing. Again, besides the incidence of prostate cancer, what does it mean as far as mortality? This data, or this graph, is looking at not only the incidence, but also the mortality rate. We do find that black men tend to have a higher mortality from prostate cancer. They tend to have a higher grade disease on diagnosis and are at a higher risk of death from prostate cancer. It decreases. Our lowest risk factor is seen in the Asian men, and there are certain theories to why we think that's the case. Besides genetics, perhaps a diet has to play into that as well, where the Asian diet tends to be more fish-based rather than the American diet, which is very big on simple carbs and red meat. And so again, to just summarize the risk factors for prostate cancer, family history is also important, particularly the paternal side. Having a father, having paternal uncles, father's brothers with prostate cancer increases more so than the maternal side, but definitely having one generation of prostate cancer increases that risk. There are certain genes that are correlated with increased risk of prostate cancer, and there's a lot of push towards helping men who are diagnosed earlier with genetic screening so that they can counsel their offspring. These genetic tests or these mutations include the BRCA genes, which is often correlated with breast cancer as well. I will tell you that one of my frustrations as a urologist include the fact that as much progress that we've made it with breast cancer, we tend to find a lag with prostate cancer. The often argument that I receive is that breast cancer is more lethal than prostate cancer, or that the incidence of breast cancer is more than prostate cancer. I'm not here to compare one cancer over the other. The diagnosis of cancer affects, just emotionally everyone that gets the diagnosis of cancer. But if you look at the incidence of both prostate and breast cancer, they're very similar. About 200,000 women will be diagnosed with breast cancer, and that roughly is the amount of men that will be diagnosed with prostate cancer. When we talk about death from breast cancer, roughly 45,000 women will die from breast cancer. And as I just shared with you, the incidence of death from prostate cancer is very similar, around 40,000. So the one downside to being a guy is that we don't talk about our health issues. And that is the biggest impediment to us receiving and helping address these issues. And it's a global problem. I mean, there's something to be said about the NFL wearing pink during the month of October, and September being Prostate Cancer Awareness Month. Most men don't even recognize that September is Men's Health Month. There's nobody bringing that attention. So we need to speak amongst each other and also not shy away from routine health care. There are other proposed risk factors. These haven't really, the evidence is somewhat soft, but more trends than true evidence. As I mentioned, diet may have a play. The Mediterranean diet, the East Asian diet tend to have more of the healthy oils and complex carbohydrates, which may be beneficial. What we do recognize is that obesity is a risk factor for prostate cancer recurrence. So that if you're diagnosed with prostate cancer and you undergo treatment and if you're obese, the likelihood of prostate cancer reoccurring is higher. And so I can't share that same knowledge or the trend with the initial diagnosis of prostate cancer. Along with obesity goes exercise. I think this goes along with just general health. Exercise is important. And the reason behind that, where diet and exercise play into increase in risk for any sort of cancer, is that we recognize cancer could be stimulated by chronic inflammation. So if the body is under chronic inflammation or a chronic state of inflammation, your body's constantly in overdrive and fighting this inflammation. And this inflammation occurs from cholesterol deposits in the arteries, lack of exercise. And so if your body's in constant overdrive with any engine of any car that's in overdrive, it starts to wear down. And so, these things increase the risk of cancers throughout our body, not necessarily prostate cancer. And so what is the overall likelihood of diagnosing or being diagnosed with prostate cancer? If you're African-American, 1 in 5 African-American men will be diagnosed with prostate cancer in their lifetime, and have about a 5% chance of dying from prostate cancer. As opposed to the general population, a little bit less, 1 in 6 or 1 in 7 men will be diagnosed with prostate cancer, and the likelihood of death from prostate cancer is low, somewhere about 1 in 30 men. So it is a very treatable cancer, and so the early diagnosis is important. And when we talk about diagnosis, oftentimes men will report to me, say, "Doc, I feel fine. I don't have any problems. I feel good. I'm able to get to work. I'm able to do my work. But why am I getting screened, or why should I go for screening of any sort of cancer, whether screening with colonoscopy or prostate cancer?" Well, truth be told, we all drive cars. We all take care of cars, and so the same could be told about taking care of a car. I mean, I drive my car. I start the engine. I get to work. I do my work. I get home. My car is reliable. I'm able to do my work and my daily chores. And I honestly could probably drive my car without getting an oil change or taking it to the mechanic for a preventative checkup. And I could probably drive this car 25, 30,000 miles without getting an oil change. But, the difference is we'll say to ourselves, well, listen, that is not a smart thing to do, because, the lack of preventative care is going to cause an early engine failure. And it just makes sense to get the oil change every 3,000 to 5,000 miles. And so that's what our bodies are like. If we don't take it for preventative care, and we wait till there's a problem, oftentimes it's too late. The difference is that, with a car, we take more attention in taking care of a car, and also you could replace a car and get another one if the thing, if the engine stops working. But we really only have one life, and there really is no replacement once that is taken away from us. So, it's imperative that maintenance is important. It's like you take your car, you got to put it on a lift to check under the hood. That's how it is with checking the prostate. You gotta come in and kind of, make sure that your prostate health is good. If you start developing symptoms, it often can be a telltale sign of it being too advanced. And those are some things like that are urinary symptoms. Changes in urination include, blood in the urine, having the need to urinate frequently, having an interrupted flow, or finding that it's difficult to start the urination, a stop and go to the urination, or I've even seen men come into the emergency room where eventually they can't urinate and now have to have a catheter to help drain the bladder. We don't want to wait till those symptoms. And often the urinary symptoms that are associated with aging, like weakness of stream, difficulty starting, waking up at night, are fortunately associated with benign prostate growth and not prostate cancer. And so often you shouldn't ignore those symptoms either, because they can be a first sign of prostate cancer. How do we screen for prostate cancer? Well, it's really two simple tests. It's a blood test that's called a prostate-specific antigen, or PSA. And what the PSA does is it evaluates a protein that is secreted by the prostate gland. It's a simple test. It should be done once a year. The PSA blood test, although it's non-specific, meaning that if it's elevated, doesn't mean that you have cancer. It can be abnormal for other reasons, such as prostate enlargement and inflammation of the prostate. But it is a good, simple test to at least pick up most prostate cancer. The sensitivity of a blood test by itself in picking up cancer is somewhere about 60 to 70%. We like to augment that by doing a prostate exam. So when you go to the doctor's office and asks to examine the prostate, the rectal exam includes, as I mentioned, passing a finger into the rectum and feeling the prostate. There are a few things that we're looking for as doctors in assessing the prostate. We're, one, getting an idea of how large the prostate is. Also, to make sure that the prostate itself is somewhat smooth, feels like the palm of your hands. It's smooth, it's somewhat symmetrical. There's a little bit of give to that when we push on the prostate. What we want to make sure we're not feeling are any sorts of lumps or bumps, which can indicate an abnormality, which will then further lead into seeing a urologist for further workup, such as a biopsy of the prostate. As I mentioned, there are other conditions that can cause the PSA to be elevated. Benign prostate growth or benign prostatic hyperplasia is the benign growth of the prostate, and as the prostate grows, it starts to squeeze on the urinary channel, making it difficult for the bladder to empty. And so that doesn't necessarily mean that you have cancer. As you get older, the PSA level also tends to rise. And that's because we recognize as a man gets older, the size of the prostate increases and can also influence the PSA. So that as the prostate enlarges, the PSA can rise. And also, as a man gets older, the PSA level can increase as well. For most lab tests, the usual cutoff is about a 4. But again, if someone is at the age of 50 who has a PSA level of 4, it may be more alarming than someone who's 75. The other thing that's important when we look at PSA level is the trend of PSA. So that's why it's important to monitor this at a yearly fashion, that if the PSA level is rising quickly can indicate a problem. But if a PSA is rising slowly over a period of time, maybe more related to benign prostate growth. And so the typical acceptance of a PSA level rise over a year should be less than 0.5 per year. And so if the PSA level is rising faster than that, can indicate more serious condition rather than benign prostate growth. Can prostate cancer be prevented? And a lot of men ask me this. Of course, they're trying to do their best to stay healthy, exercise. So there isn't anything that's out there that can help prevent prostate cancer. I suppose if that was the case, we as doctors probably wouldn't have a job, as everybody would pursue an intervention that would prevent cancer. But in general, this goes along with all sorts of cancers, whether it be colon cancer or prostate cancer. Smoking is important. So if you're a smoker, you should stop smoking. You can reverse some of the effects of smoking over a period of time of stopping. And I often have that debate in men who say, well, I've been smoking for 40 years. What's the point of stopping? Well, there is always an advantage to stopping, advantage to stop smoking. Healthy diet is important. As I mentioned, that chronic inflammatory state your body is in if you're not eating healthy. Healthy diet includes a well-balanced diet, helping to reduce animal protein, especially red meat. Physical activity is important. And again, there's no such thing as a good idle engine. You want to keep that engine running and keep your body in physical activity. I often get from patients that, hey doc, I work hard at work. I'm constantly on my feet. That, yes, it's considered physical activity, but you really ought to dedicate 15 to 20 minutes to really exercise, exclusive of how strenuous your work is. You want to get your heart rate up and dedicate 50. That's all you need, 15, 20 minutes every day. And so just in general, when we talk about these things to help prevent cancer, still the number one cause of death in the United States is heart disease in men. And then diabetes is approaching astronomical levels. So just in general helps kind of knock off or control some of the other risk factors for death in the United States in men. If one is diagnosed with prostate cancer, and by no means this lecture is as in depth, when we could spend an hour just talking about each of these treatment options, just want to give a brief overview of what the treatment options are. And again, you can kind of further get information on my website at www.singhurology.com. That again is SINGH, urology.com. The treatment options can include active surveillance. We do recognize that most prostate cancers are indolent and most men will die with cancer rather than from. So that although I may be accused of being a prostate snatcher, that's not the case all the time. And we recognize the changes over the last 10 years, the importance of managing prostate cancer and monitoring. The problem is that if we don't even pursue an understanding of a PSA elevation or even coming to the doctors for an exam, we may never know what type of cancer a man has. And so that active surveillance, I have many men on active surveillance. If a man is diagnosed with low-risk prostate cancer, we often encourage active surveillance. When we look at the National Cancer Comprehensive Network, or also known as the NCCN guidelines, the first or the preferred treatment for men who have low-risk prostate cancer is active surveillance. Of course, there are many things that go into play in recommending active surveillance. That includes your PSA level to be less than 10 and a Gleason score on a biopsy to be 6 or less. If you're not a candidate for active surveillance or you don't choose to undergo active surveillance, the following are treatment options that are recognized and a way to treat prostate cancer in the United States. The two main ways we treat prostate cancer are removal of the prostate, also known as prostatectomy, or radiation therapy, and there's a slew of different radiation treatment options that are out there. Less preferred or less common include freezing the prostate or cryosurgery, or something that is approved by the FDA but has still a limited data, includes high-intensity focused ultrasound or HIFU. And so most men will often be provided the top 3 ways to intervene for prostate cancer. And so, as I mentioned, active surveillance may be a choice for many, and that's because we recognize that most prostate cancer is not lethal. We develop an algorithm to actively monitor the cancer. This often includes a regular PSA check, a regular prostate exam. It may not be a good treatment option for somebody who perhaps has a lot of anxiety. And I do have some patients who are not good candidates, primarily based on the fact that they are losing sleep over the fact that they've been diagnosed with cancer. So I have men who say, Doc, you're telling me you have cancer. It's keeping me up at night. I don't know what it's going to do. It's just really taking a hit on my quality of life. I'd like to treat the cancer. So there are some men who are not good candidates just based on that effect of quality of life. We employ many things in making sure that the cancer is a low-risk cancer. The last thing I would want to do is to reassure somebody and find out that here we think that it's a flock of sheep, but really it was a wolf in a sheep's clothing. And so we employ many things in my practice, including genetic testing. Oncotype DX has been a test that's been out with breast cancer for several decades now. And we're starting to, over the last decade, employ this in prostate cancer. It helps risk stratify, or all these tests help risk stratify the tumor at a genetic level. And so when we do a biopsy, that is a microscopic evaluation, and at the pathologist interpretation in assessing how much disarray the cancer or the prostate cancer cells are in, this takes us down to the RNA and DNA level. And often we'll reassure a patient in saying, listen, the results are favorable, that the genetic testing is in line with the biopsy, that we can continue to monitor the cancer. Or I've had several patients come back at a high risk and we end up pursuing treatment like removing the prostate and finding out that truly they had aggressive cancer that the biopsy did not pick up. These tests are done on the specimen of the biopsy. It's not a blood test. It's not something that we use to screen. It is based on the specimen that we obtain at the time of biopsy. When we talk about definitive treatment options, we talk about prostate removal. And I will tell you that we have come a long ways in the last 15 years in treating prostate cancer. I myself have been treating prostate cancer with removal or surgery and have not relied on the open approach probably in the last 12 years. This is something that was more common about a decade and a half ago. It still happens in the United States. It's usually a surgeon preference who's not robotically or laparoscopically trained. I'm happy to share that we've been doing robotic surgery at Montefiore St. Luke's since 2007. And we have plenty of experience and a team that helps treat prostate cancer. And I can't remember the last time that I've had to resort on the open technique. But to be complete, what the open surgical technique is usually an incision that extends from the belly button down into the pubic bone. So it's a surgical incision that measures probably close to about 6 to 8 inches. And that exposure allows us to get to the prostate, as we had reviewed in previous slides, where the prostate sits is just below the bladder and in front of the rectum. Some surgeons will use what's called the perineal approach. It's becoming less and less favorable because this particular approach, the perineal approach, where the incision is made under the scrotum, does not allow us to sample the lymph nodes which are in the pelvis, and this approach doesn't allow us to get to the lymph nodes which are important in staging of prostate cancer. So when we talk about robotic-assisted approach, we use what's called the Da Vinci surgical system. The Da Vinci surgical system has been FDA approved since the year 2000. And we use this technique primarily because of the incisions that are made in pursuing this treatment are much smaller. They're usually keyhole incisions measuring less than a centimeter, and it allows us to obtain better visualization, as the magnification on the scope is upwards of 8 times in zoom. The other advantage of the robotic technology is that, where us human hand has certain tremor to it, and as a surgeon is operating, there's always a concern of a hand tremor, the robotic technology actually dumbs down the tremor. And so even though a surgeon may have a tremor, the robot will negate that tremor. And so it really is a fantastic technology that's allowing us to offer patients a successful cancer treatment option with less blood loss than the open technique, less pain, less hospital stay. Our patients here at Montefiore St. Luke's are typically spending only 1 night in the hospital and going home the next day, which allows quicker time back with their family, recovery at home, and typically back at work within 3 to 4 weeks. There are certain side effects to prostate surgery, of which, again, the robotic technology has allowed us to really preserve the tissue that's in and around the prostate with magnification and the delicate hands of the robot. The things like what we traditionally refer to as side effects from prostate surgery as leakage of urine and changes in erections. Urinary incontinence, or the loss of leakage, is something that a man will experience after prostate removal. In the very beginning, almost everyone will experience that, but with time, it does get better. Our typical recovery is usually 3 to 6 months after surgery. I am finding with the robotic technology, most men, I would say close to about 80 to 90%, are pad-free by 3 months after surgery. With open techniques, that tends to be somewhat delayed, where the recovery can take up to 12 months. The nerves that are important to provide stimulation to the penis, as I mentioned, run closely and intimately to the prostate. We do our best to save these nerves. Sometimes patients' prostate cancer is advanced and we can't save the nerves. and can result in changes to the erections. Erectile recovery after prostate surgery can take time, but when we talk about both urinary incontinence and erectile dysfunction, they're both are treatable conditions. And that's the other advantage of seeing a surgeon like myself, that we often employ interventions early to help recovery, such as Kegel exercises, biofeedback or physical therapy to help patients recover urinary leakage, and things as I like to label as penile rehabilitation, where we include things like use of vacuum device, early vacuum device, and early use of prophylactic medicines like Viagra to help with blood flow stimulation. And so these are all important. We recognize side effects, but there are algorithms that we have in our practice to help with early recovery. The other interventions besides surgery include radiation therapy, and there's a whole slew of ways we approach radiation therapy. We have things like brachytherapy, which includes seed implants that the radiation oncologist with the urologist in the operating room will place radioactive seeds into the prostate. The radiation then is given at a low dose over a period of 6 months. Not everyone is a candidate for seed implants. Often depends on how aggressive the disease is. There's things like external beam radiation therapy, and there are many ways to deliver radiation, whether it's image-guided, which really is the standard of care. It's image-guided with a patient getting some sort of imaging, such as a CAT scan, at the time of the delivery of radiation. It typically includes a regimen of 6 to 8 weeks, and sometimes may need medications to help lower the testosterone, or what we refer to as androgen deprivation therapy. These are injections to help lower the testosterone, to help slow down the progression of cancer so that the radiation can be more effective. The radiation, when it's given from the outside, can be stereotactic. It allows a shorter time period of radiation, where typically, as I mentioned, 6 to 8 weeks with image-guided or with proton beam. Things like CyberKnife or stereotactic can reduce the frequency of radiation down to as little as 5 treatments to upwards of 8 to 10 treatments. So it does cut down the time of delivery of radiation. As with anything, there are always certain side effects and risks with radiation therapy. Because the radiation is given to the pelvis, as I mentioned, there are adjacent tissues that can get affected, including the rectum, which sits right behind the radiation. So that damage to the rectum can result in bowel issues, including rectal bleeding, diarrhea, and the need to find a bathroom to release the stools in an urgent fashion. I've also had some patients have leakage of stool, which we classify or label as fecal incontinence. Most of these symptoms, fortunately, get better over the 6 to 8 months, even after when radiation ends. The likelihood of these symptoms to persist at 6 to 12 months after radiation are low, but men who do experience rectal bleeding, the 2 to 3% that are severe can be somewhat severe. Urinary dysfunction, so that men who have radiation therapy don't necessarily experience leakage of urine with activity as you would with prostate surgery, but urinary dysfunction, as we label as broadly, can include irritation to the urinary tract, where one can experience urinary frequency, the need to urinate more frequently than every 2 hours, the sense of urgency where you have to rush to the bathroom, and sometimes leakage of urine on the way to the bathroom. This can result also waking up several times a night. And so although most of these symptoms do get better as the radiation settles down and the prostate recovers, but they can persist for some time in a handful of patients. And so again, the other thing that gets affected are, again, I keep going back to the blood vessels and the nerves that are important for erections. They are in the way of radiation. So men over a period of time will experience these changes. The one difference between radiation and surgery is that the erectile dysfunction occurs early, obviously with surgery, and gets better with time. With radiation, things are initially better, and with time get affected, because radiation initially will affect cancer cells, but also will affect normal tissue over an extended period of time. And so as an oncologist, as a surgeon, surgical oncologist that manages prostate cancer on a daily basis, I really take the quality of life issues that men face after prostate cancer treatment. And so there's a big part of my practice that I refer to as life after prostate cancer. We have an upcoming seminar that's sponsored through Montefiore St. Luke's, October 14th. And so there will be more information that to come, and would be love to engage in better looking at these treatment options. And so I just left it here just as a quick summary, but we can delve into the more nitty-gritty of what those treatment options are. This is the diagram of why men experience leakage. When we take care of or remove the prostate, the only thing that's left to help with controlling the urine is the sphincter. And so as a surgeon, I have to do my best to remove the prostate and the cancer and to leave the healthy tissue, or in this case, the sphincter or the muscle that controls the urine. It's not uncommon to have leakage, and it does get better with time, but in the United States, 10 to 15% of men will experience some leakage after prostate surgery. Of course, surgical experience matters. You want to see a urologist that is comfortable with or has a good experience with prostate removal. And there are surgical options to help with urinary leakage and also help with restoring sexual health. And there's a whole slew of ways we help men with restoring erections after prostate surgery or radiation. That can include oral medications, injections to the penis to achieve an erection, and also surgical interventions such as penile implant surgery. So in summary, I hope that many of you learned a lot from the session and take the due diligence in exploring further on our website, and also our Montefiore St. Luke's website has a good amount of information. So on that note, I will conclude tonight's seminar. And once again, thanks to Montefiore St. Luke's for sponsoring this event, and to the audience for participating in listening to the lecture.